Yeah.
All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today we have a lot of things to discuss, so I'm going to try to keep it as compressed as possible. The basic discussion that I want to do is about the AstraZeneca approved by the UK government for the emergency usage. At the same time, UK government has decided to delay the second dose for Pfizer and AstraZeneca both. So just one second, I have Luffy here with me. नीचे रख दो. So here is Luffy. So this is the guy who makes all that noise all the time. Luffy, what do you think? You know all the COVID things? Yes? Luffy? Look here. You know COVID? Why don't you let me talk with my friends? So Luffy always thinks that whenever I am talking with anyone, I should actually be talking with him. So that is what causes Luffy to make all those noises. So of course he's becoming now restless. So Luffy, you want to go now? Okay. All right. So Luffy's going to go. Cool. So that was Luffy. Jim, welcome. Welcome, France. Welcome, Shahida. Welcome, Chantal. There are so many folks. So we have Luffy online today. So one is the AstraZeneca and their approval. Second is the interesting, curious thought on the UK government side to delay the vaccine, second dose of the vaccine. So only give the first dose and give it to a widespread of the population. And then thirdly, I also wanted to discuss once again the fetal tissue issue, because with AstraZeneca, this is something that would become even more prevalent. And I wanted to say that, number one, I am not an expert on religion, especially on Christian religion. I cannot be, not even close to being naive than an expert. That's one. Secondly, I'm not aware of too many denominations within the Christianity, so that if I can talk about one denomination's belief system and I can be judicious to the others, I cannot do that either. So what I'll do is this: I'll present what I could find, and I'm sure that you can find it better. But I would try to present some of the thoughts from various religious leaders as well. So you can tell that there is a lot to work with. So, and then there is the new year as well. So happy new year to everyone. And I would see you after a year. If you are okay with this, I would take tomorrow and day after off. So the new year and the Saturday. And if you would like to continue, then I would continue as well. I think these are the second successive 2 days off after the Christmas. So hopefully that will be great and that will be okay. So with this, let's start. So happy new year to everyone. So here we are. The first thing is that the UK has granted EUA for AstraZeneca vaccine December 31st. And with a curious, I do not know why I wrote an over here, with a curious decision of delaying second dose. Now, let's look at the AstraZeneca vaccine quickly. Vaccine used to be called ChAd-OX1, ChAd-OX1. And we have talked about it many times in the past, so I'm not going to go in the detail of the vaccine. I have done many discussions. This was I believe by the Oxford College that they built it, and then they have partnered with AstraZeneca, and AstraZeneca is producing and distributing it. The vaccine's name originally stood for chimpanzee-based adenovirus, which was built in Oxford and the version 1. That is the name. this vaccine is actually based on an adenovirus. Adenovirus is a common cold virus. It is taken from chimpanzee instead of taking our common cold virus. That is because the other animals' viruses, other than the SARS-CoV-2, other animal viruses find it difficult to work with our cells and to infect them and to replicate. So it is difficult for them to kind of expand in our body. Number one. Number two, as I've discussed in the past, this virus that will be carrying the spike protein genome, that virus does not have the replication gene in it. So they have altered the virus so that it cannot replicate in our body. So it cannot increase in number. Whatever number of viruses with the spike protein RNA they would inject in us, that is about it. These viruses would be picked up. They will be then destroyed, and the RNA would make spike protein. That spike protein would also be destroyed, but in that process, it would prime our immune system. So I know that in the previous discussions, there have been many times the comments like, why would I want chimpanzee adenovirus in me? So that is totally your choice, your decision. However, this is how vaccines are made. The adenovirus vaccines are made this way. So they are these things. Secondly, the fetal tissue issue is still there. I was reading a comment on one of my previous AstraZeneca discussion where I had talked about that woman who has incorrectly presented a video where she has said that there is fetal tissue and all that. So remember I talked about it. So somebody had put a comment there which was interesting for me. There are many, many comments. So I'm of course at the butt of the jokes for the anti-vaxxers at this time. And one of the comment in there was that somehow I am a non-religious person who does not respect other people's religions, and I have no humanity and I do not know many other such things. But the thing is, even in there, I had discussed that here is how this is built. The choice is yours, and I had also discussed how various religious leaders are looking at it. So I think that some people just look at the title and they feel compelled to put a comment without actually listening to the video. So let's look at the fetal tissue issue over here. This particular vaccine, I've done this discussion in detail before, so I would not do it again here. This particular vaccine is built by creating an RNA of the adenovirus. So what they do is they create the RNA, or they take the RNA or DNA of the adenovirus. That is the first thing. Then from this virus DNA, they remove the replication gene, the gene that allows it to replicate. So now this is just one virus and it cannot divide further or replicate further. Then what they do is they add to this DNA the spike protein DNA. So they convert the spike protein RNA from the SARS-CoV-2 into a complementary DNA, and then they attach that DNA in here. Now they have the genetic fingerprint. You can say that they have a recipe, but how do they make a virus from this recipe? So what they do is they take this recipe and add that to our cells, not our cells. These are the copies of the fetal tissue cells. So this vaccine is manufactured. This vaccine is a adenovirus itself. So if I make that adenovirus over here, when the virus will be formed, this is the virus. Inside the virus, the genome of the virus will contain this thing, and that would be, it will contain the DNA for the spike protein, actually RNA for the spike protein. This virus needs to be built somewhere. They have the genetic fingerprint here, or genetic material here. So they inject this genetic material into these cells. These cells are the copies of the HEK293 cells that came from Netherlands, from a female fetus that was electively aborted in 1972. So these cells here, so since that time, so how much time is now gone? 72, so 30 years, 40 years, 50 years. So about 50 years, they have been making copies of these cells. So those copies are present all over the world in various labs. And they are used for making medicines, and they're used for making these kind of viruses. This cell, HEK293, has a special change in this. And the change is, if this DNA, think about it for a second with me, when this DNA is injected into this cell, that DNA will get converted into one adenovirus. But we want this cell to manufacture millions or thousands of adenoviruses. We don't want it to just make one adenovirus. So what they do is, or what they had done was, in 1973, they took the original cell and they changed it. What was the change? This piece of replication gene for the adenovirus. Remember, they take the adenovirus DNA and remove the replication gene. They actually inject that gene in here. So when this DNA is added to this cell, this replication gene is already present. It would allow this DNA to be replicated again and again. So this is not happening in our body. This is happening inside the lab. And it would help make thousands and thousands of these adenoviruses. So once many thousand adenoviruses are made for each cell, then what they do is they break this cell open. We call it lysis. They lyse it. Lyse mean breaking it, they're dissolving it. So they break the cell, and then they extract these adenoviruses from the cell. They then bottle up these adenoviruses, and that is the vaccine. So in this vaccine, ideally, there is no fetal, so copy of the fetal tissue cell. This cell is not in here. It is not in here, number one. Now, number two, to be more precise, it may be possible that the broken cell has some pieces in it. Some parts of the broken cell, just like when the mirror or a glass breaks, there may be one small thing from the glass that goes in here. Although AstraZeneca says that our purification mechanism, that means the mechanism that would extract this adenovirus after the cell has been broken, these are great mechanisms, and we make sure that there is no possibility of the cell proteins to go in there. And I can tell you why this is important for them. The importance is that they do not want any other antigen to come in through the vaccine. So they would have to figure out mechanisms. And of course, if they can figure out the mechanism to build a virus, they can figure out mechanisms to purify it as well. They will have to figure out mechanisms to clean or wash the virus off of any cell debris on it. So that is what is the actual situation. That means, compared to Moderna and Pfizer, this vaccine is a little more closer to the fetal tissue issue, that it is built into the copies of the fetal tissue. With this now, I'm going to show you some of the messages from various religious groups, and I'll give you my opinion as well. So my opinion is not going to be Muslim opinion or Christianity's opinion or Hindu or others. It is just my professional opinion. I believe in organ donation, number one. Number two, I totally agree that folks say that there was an innocent life that was aborted. Totally wrong. I agree with that. Then the interesting thing for me is that when somebody dies and they have donated their organs, and somebody lives with those organs, they get a lot of credit for this service to another human. May that be their lens is used, or their liver is used, or their kidney is used. I am an organ donor as well. This child, this soul that was aborted, eventually her cells are serving humanity at a very large scale. In my opinion, the blessings she has for the service her cells have done is tremendous. Again, I am not going to be saying it was right or it was wrong. That is a different discussion. But at least her cells has served humanity. She would get the blessings for that. Now, with this, I also wanted to share how. So on the manufacturing of it, HEK293 cells, there are copies of those cells. These cells were transfected with the adenovirus replication gene. This fetus was aborted in 1972, female fetus, legally aborted under Dutch law. So that is the basic thing. And now let me show you some of the discussions about this. And once again, I'm not going to be able to do justice to this discussion. And the choice of using it, the vaccine or not, is yours. So here the Vatican says that it is morally acceptable to receive vaccination for COVID-19, even if the vaccine's research or production involved using cell lines derived from aborted fetuses, given the grave danger of the pandemic. Then there is one more comment here. The Congregation for the Doctrine of the Faith, the Vatican office charged with promoting and defending church morals and traditions, said in a document released Monday that when ethically irreproachable COVID-19 vaccines are not available, it is morally acceptable to receive COVID-19 vaccines that have used cell lines from aborted fetuses in their research and production process. So Pope Francis approved the text on Thursday, Vatican News reported. Then there is one more comment here, which I thought was interesting. And again, I do not know the denomination. So I do not know who will agree with the Vatican's message and who will not. So I saw one more post here. A Pew Research survey in September found that fewer than half of Protestants, 43%, said they definitely or probably would get the vaccine. That includes about a third of white evangelicals and Black Protestants, Catholics, and non-evangelical white Protestants. 54% were more likely to say that they would get vaccinated. 71% of atheists and 68% of agnostics, on the other hand, were ready to be vaccinated, but only 48% of those who are nothing in particular. Then Barros said the leading vaccine from Pfizer and Moderna appear to be both effective and ethical because these two vaccines are not manufactured in the fetal cells copies. That would make them important tools in combating the coronavirus pandemic, which is why the Christian medical and dental associations encourage their use. So now the basic dilemma to think about for those folks who have a belief system that includes this fetal tissue issue is to say, if a vaccine is manufactured in those cells, are they comfortable taking it or not? If not, then that is their choice, that is their faith. If they are, that is again their choice and faith. And if that is not the case, we do have an alternative, and that is Moderna and Pfizer. So that means it is possible that there are some people who would refuse AstraZeneca and choose Pfizer or Moderna for this reason. Now, Billy Blog has a comment here. Would it be a problem if the cells were not from fetuses? So there are many reasons for this, Billy. Yes. The one reason is to continue to make copies of the cell. Secondly, our cells that have become adult cells, they are usually they contain a lot of other proteins that we have learned to make, and we make them for our functions, which will taint the manufacturing process and the viruses. So there is a problem. I still believe that the medical industry should get rid of this issue altogether by taking adult cells, converting them back into stem cells, and then using them for vaccine manufacturing and drug manufacturing and so on. So I think that this pandemic has kind of poked an issue which, instead of we individually saying that, hey, you know what, Mubin sucks, and why are you talking like this, and you should not do it, and we hate you, I think the folks should come together and try to work for a solution. And if that solution is to say, take adult cells, living human person cells, just like an organ donor, and then convert them into stem cells and then use them, and maybe pressure these companies to say, we would only use those drugs that are manufactured in these kind of cells other than the fetal cell copies, maybe there would be a solution there. Cool. So with this, I want to continue because we have a lot to discuss. Then here, I had shared this in the past as well. I have shared this once again. All of these links are in the description as well for your reading pleasure. Here, what this article has done is that it has taken various vaccines that are built using the fetal tissue cell lines. So for example, if you see here, CanSino is built in HEK293. That is the same vaccine where AstraZeneca is built. Then same cell line. University of Oxford, AstraZeneca, HEK293. HEK stands for human embryonic kidney cell line. Janssen Research and Development, which is, I think, associated with Johnson & Johnson, PERC6, that is also a cell line. University of Pittsburgh, HEK293, and then another vaccine, 293 and EC7. And then here they have also gotten some discussions about the religious belief system and then the validity of these cell lines or not. So I'm going to continue to move on. Second thing now, AstraZeneca. The result for AstraZeneca, I actually have a problem with the AstraZeneca's result reporting. Here is a problem which I have. AstraZeneca they had 5 trials done. Out of those 5 trials, there were some that were in UK, some in Brazil, some in other countries. And I think you all know this, all cool beans know this, that they had done 2 types of trials. In one trial, they had given 1 full dose, and then a few weeks later, the second full dose. And then they did 1 more trial where there was half dose in the beginning and full dose later on. And I still have not figured out why they decided to do the half dose. I think it was accidental, and they just stuck to their guns and said, you know what, this was planned. I do not know the thing. If you know better, please place a comment where I can actually educate myself as well. The result is this: half dose and then full dose, 2 doses, first half dose, second full dose, created an efficacy of 90%. And I talked about it in my previous AstraZeneca and in detail. The full dose, or what they call standard dose, 2 doses, that created an efficacy of about 60 to 62%. Then what they do is, this is where I have an objection. Then what they do is they said, fine, one kind of trial produced 62% efficacy, other produced 90% efficacy. Overall, we have 70% efficacy. They grouped them together. In my opinion, 2 separate dose groups should not be connected together and then averaged like this. What are they going to do with this efficacy? Now, are they going to say, okay, give half the people 62% efficacy dosage regime and the other 0.5% this dosage regime, and that is what it is? So I think that this was a little bit incorrect. And the problem with this regime, 90% efficacy regime, where there is a low dose and a standard dose, as they call them, they do not have a way to explain it, that why did that happen. So is that really something that can be done? If that can be reproduced and done, then this is a good thing. But this is the problem that I have with their reporting. I would probably choose this to say, just stick to this one, half dose and full dose, and then just go with that. After that, another, and I'll go over the document in a second that UK government has looked at to approve them. But I also wanted to talk about one more thing which has been very interesting, and that is UK has decided to give one dose to as many people as possible and then delay the second dose. And of course, that can become a mess as well. And I want to show you some of the interesting things here. One second. So here, this is the document from AstraZeneca about their efficacy. We'll look into that in a second. But if you see here, this is a Pfizer BioNTech, because UK, I believe, has decided that Pfizer BioNTech, what is that? Dosage, second dose will be delayed as well. So this is one such explanation from the UK government to do that. And then here is another letter. This letter is from the frontline doctors in England or in UK who say that we are concerned about this dosage issue. So what I'm going to do is that after discussing that how concerned we should be, I'm going to explain that is there really a concern? Should we be concerned or not? So let's look at that. First of all, I'm going to start from this thing that I had drawn here. The way AstraZeneca is tested is the following way. In UK, so if you see here, this line, in UK, what they had done was, and I'll show you that in their document in a second, first dose on day one, whatever day that is, then the second dose is within 12 weeks time. And UK has said that now the second doses will be given between 4 to 12 weeks. And that is a problem for Pfizer's vaccine. For the AstraZeneca, their trial included up to 12 weeks for the second dose, which means up to 3 months. So you get one dose today and then 3 months later, the second dose. And they calculated the efficacy 14 or 21 days after the second dose. This is how AstraZeneca measured. So up to 12 weeks in the UK trial. In their Brazil trial, first dose to second dose, the distance was up to 6 weeks. So again, that is in their document. I'll show it to you. And the efficacy measurement was from the 14 to 21 days afterwards, after the second dose. This was AstraZeneca. So I can actually think about AstraZeneca to have the second dose delayed because they tested it that way as well. On the other hand, Pfizer said that, hey, we only tested first dose on day one and then second dose within on the 21st day. That is 3 weeks. And then the efficacy count starting from 7 or 14 days after the second dose. So now Pfizer is crying foul, saying we never said that the vaccine is efficacious if given after, let's say, 12 weeks, the second dose. And they're saying we don't have data. To that, some people interpreted that as saying Pfizer BioNTech is saying this is wrong, don't do it. I looked at their statement, they are saying we don't have data. And then I had to go dig in their data to say that they are actually saying wrong. So let me show you. So I'm also going to look at technical side of it to see if the government is deciding correctly or not. But first, I want to look at the data with you. So I'm going to look at Pfizer's data first, and then I'm going to look at AstraZeneca's data. So here is Pfizer's data. And I had written their page numbers so that I can remember which page numbers they have. So page 29, 31, and 32. So if I go here on their page 29 here, this is Pfizer's document that was published by the US's FDA while they were reviewing them for approval. Look at this here. Based on the cumulative incidence curve for the all available efficacy population after dose 1, COVID-19 disease onset appears to occur similarly for both BNT 162, the vaccine name, and placebo groups until approximately 14 days after dose 1. So from the dose till the 14 days, there is no benefit of the vaccine yet. And it makes sense because the immune system is not yet ready. But from 14 days onward, after dose 1, what is it? Look at this. At which time point the curves diverge, the difference starts appearing, with more cases accumulating in the placebo group than in the vaccine group. And there does not appear to be evidence of waning protection during the follow-up time of approximately 2 months following the second dose. So their document actually shows that there is efficacy after the first dose, but 14 days after the first dose. And that actually is fine because the antibodies can start getting produced afterwards. Now let's see more. That is at page 29. Then here in the page 30, the vaccine recipient who had severe COVID-19 disease met the severe case definition because oxygen saturation at the COVID-19 illness visit was 93%. And I have something here. No, so this is the second dose here. In all available efficacy population, meaning everyone, 10 participants had severe COVID-19 disease after dose 1. After dose 1, 1 subject who received vaccine and 9 who did not. So severe disease occurred after dose 1, 9 cases in placebo, 1 in the vaccinated group. 5 of the remaining 6 placebo recipients who had severe COVID-19 disease who hospitalized, 2 of whom are admitted to an intensive care unit. So once again, they are showing efficacy here after dose 1. So after dose 1, before dose 2, vaccinated group, severe or secondary endpoint, first severe case occurrence, 0 and 4 on the placebo side. So as much as I don't agree with UK government's idea of delaying the dosage, at least the data from Pfizer shows that from dose 14 days after dose 1, there will be some level of protection. We are saying, what is that protection? So from severe disease, 100% protection. Now, one more here. Look at this. After dose 1, before dose 2. So this is the first COVID-19 occurrence. So you have given the vaccine, and now you're waiting for the COVID-19 to occur. And now after dose 1, but before dose 2, if you see here in the vaccinated group, 39 out of 21,669. In the placebo group, 82 out of 21,686, that is 52.4% efficacy. So efficacy is present, but it is 52%. From severe cases, it is 100%. That means if 1 dose is given, then after the 14 days of the dose 1, from this data, we can say that severe cases will not occur, and there would still be infections in the vaccinated group, 1 dose only, and that would be 52% better than placebo. I think that is still a better thing. That is still a useful thing. That is still valuable. So the vaccine efficacy for the prevention of COVID-19 disease after dose 1 is 82% in the all available efficacy population. This is another data point, 82%. Based on the number of cases accumulated after dose 1 and before dose 2, there does seem to be some protection against COVID-19 disease following one dose. However, these data do not provide information about longer-term protection beyond 21 days after a single dose. Why beyond 21 days after a single dose? Because at 21st day, they had given the dose 2. So it is not that they did not give the dose 2 and continue to monitor people with one dose only. So that is what they're saying. We don't have data for one dose continuously. So now if we became scientists for a second and we looked at what will happen after 21 days, let's think about it. We know that natural killer cells, NK cells, dendritic cells, and macrophages, the innate arm macrophages, within the first 24 hours of the vaccination or the infection, these cells will become active. They will pick up the antigen, they would digest it, destroy it. So somebody had asked me that those spike proteins that are formed, where are they going to go? Are they going to live somewhere in our body? No, so these cells actually pick them up and they destroy them, they digest them, they break them up into smaller tiny pieces, which are called epitopes, and then they present them on MHC2 if they are antigen presenting cells. On MHC2, so they do not present the whole spike protein, they have already chopped it up into tiny bits, and then they're showing those tiny bits, which then causes, so you can say they're digested, they're gone, which then causes the naive T cell to become activated. And we've done that discussion. In the absence of interleukin 12 and in the presence of interleukin 4, the naive T cell becomes T helper 2, which causes the B cell to become a plasma cell, and plasma cell will make antibodies, correct? This process, and there is interleukin 4 and interleukin 5 that is released. And this process can take anywhere from 7 days to 14 days or more. And this is why the vaccine would become effective after 14 days. In some people, it might become effective after 7 days or 8 days. In some people, it might become effective after 20 days. So they have a 14 days cutoff point. In some cases, if the interleukin 12 is present, then the naive T cell will become T helper 1 cell. And the T helper 1 cell will release interleukin 2, and that would cause the cytotoxic T cell to become active, cytotoxic T cell to become active, and that would start killing those cells that have the antigen presented on them. This whole thing takes anywhere from 7 to 14 days. Then we know that these guys continue to protect for months. So they will protect for months. And if you're trying to figure out that am I pro-UK government at this time or anti-UK government, I think what I'm presenting is the scientific fundamentals of the problem. Then we can think for ourselves at what can happen. So I'm not pro or anti, I'm just trying to figure out that the decision can result in what. So then the protection would continue for months. Now, that means we can say, all right, just give first dose and there will be protection. The problem is this intensity may be low, enough low that it does not prevent the rate of infection that we want from the vaccine. For example, we have said that the vaccine should protect 95% of the times. Now it cannot do that because people are running around with a lower immunity to the virus. So when the actual virus will arrive, only 52% will still be primed enough to fight with it, and the others will not. That is the risk. So the important thing to note is that can they become severe? And from the data, it shows that they may not become severe. Will some of them die? They do not have that data. And that is what Pfizer is saying. Pfizer is not saying, don't do it. Pfizer is saying, what we had a contract on, the trial that we did, and the usage that you're saying are two different things. So don't hold us accountable. You are making this decision. So that is what is Pfizer's point of view. AstraZeneca, on the other hand, is saying that because we were tested this way, that the second dose may be 12 weeks later, we are okay. So AstraZeneca's, their announcement here says, here if you see, this is their announcement from today, 30th December. They're saying UK Medicine and Healthcare Products Regulatory Agency has provided authorization for emergency supply of COVID-19 vaccine, AstraZeneca, formerly AZD1222, for the active immunization of individuals 18 years or older. The authorizations recommend 2 doses administered with an interval between 4 and 12 weeks. And AstraZeneca is okay with that because in their document, if we go to their document now, in their document, they actually say that the trials, I had to read this all today, including the religious things. So if you see here, read this part. With most participants in the UK receiving the booster dose more than 12 weeks after the first dose, and most participants in Brazil receiving their second dose within 6 weeks of the first. So in the UK trial, 12 weeks and more, and in Brazil, 6 weeks. So AstraZeneca has no problem with it because they're tested that way. Pfizer has a problem with it because they do not have data and the vaccine will be used in a way that it is not tested. Now, if we became scientists once again, should we be concerned? There are 2 concerns that I have. Number one, Pfizer's data already shows anywhere from 52% to 80% efficacy. So they're already showing that the efficacy is low. And secondly, they do not have data beyond 21st day for the first dose, because first dose people were always converted to second dose. And because of the missing of this data, they are concerned. I am not very much concerned. I believe that this efficacy will hold beyond 21 days as well. How long will it hold? I think it is going to be the same behavior as with the remaining antibodies, that the antibodies will appear, they would be higher in the beginning, the titers, the levels, and then they would start declining. And if the virus actually arrives, then they would be shot up, they will be produced again, and they would do their function. Now, if you ask me this question, that why will the intensity be low of this immune response? And the answer is very simple. The immune response is based on a couple of things in such situations. One is the number of, let's say, plasma cell copies, number of copies of B cells. We call it proliferation in medicine. Proliferation means increase in cell numbers. With a smaller dose of the vaccine, it is possible that when B cells are formed, their numbers, let's say, with the small dose, their number are 100,000. When you give the second dose, now these 100,000 which were produced from one cell are now, so we had 100,000 cells, and once again, let's say they get 10 times proliferated, they will be 1 million cell now. Correct? And so the intensity of the response will be more after the second dose. Intensity of the response will be less after the first dose because the number of cells are less. That is one reason for the weaker response. The second reason is that the cells, the B cells that are sleeping in our lymph nodes, the memory B cells, remember we had talked in the past that they keep their hands open, that means the receptors, and they are sleeping. So here they are sleeping cells while they look like awake. So sleeping is like this maybe. So they're sleeping. They is sleeping with a expression on his face. And then the follicular dendritic cells. There are more cells in the follicles. These dendritic cells will capture the antigens, let's say the spike proteins, and continue to present them to these sleeping cells. And these sleeping cells will continue to become refined. This is called affinity maturation of the cell, that you keep giving them antigen, you keep showing them the antigen, and they keep honing their craft of binding with it. Just like virus is trying to mutate its spike protein, our cells continue to change their binding site as well to refine it to bind better. This affinity maturation will not occur if the second dose is not given. So further honing of the cell's capability to bind with the virus will not be as great as it will be after the second dose. So I can say this, that the immune system's response will be weaker, but it will not be absent. And of course, that means efficacy has reduced. Now, should UK do this? I think with AstraZeneca, they should be fine because that's how it is tested. For Pfizer, they should not do it. They should continue to give the Pfizer in the dosage that is necessary. Their reasoning is that we feel it would stay efficacious, and we feel that we have to give vaccine to masses so that this continuous cases and the death rate that is going on at this time, that is halted. And maybe people become mildly symptomatic and we can manage them and we can bring them back home, but at least we start preventing deaths. I think that is a reasonable thing to think about, but there is a risk that they may actually botch the whole process with Pfizer, and we may not get the efficacy that we are speculating over here. So this is the discussion for today. I went on for 48 minutes. I'm sorry. It's a new year for you as well. So are you okay if I take tomorrow and day after off and meet you on Monday? And I'm here on the when is question period? Wayne, so tomorrow and Saturday. So I'll come back on Monday. Jenna, Happy New Year to you as well, and have a good night. Excellent. So let me just very quickly, so Jenna Smook, you're very welcome. Thank you, Loretta. So very good. Happy New Year. Enjoy. And I'm going to just very quickly see if there is any question here. If not, then we'll see each other on Monday. Derek says they couldn't wait to rush these killer concoctions out. I don't think that these are killer concoctions. They are actually going to help. So this is actually a very good point, Jan. Dr. Bean, please speculate about preventing long haulers with just one dose. Many problems arise from trying only to reduce deaths. And I wanted to actually talk about this as well, that some of the folks had put this comment out that because of the increased cases, the virus, because of the increased virus's infectivity, the virus's lethality is bound to increase. So I wanted to talk about that. Let me share my screen for a second. When we say that the virus has become more infective, that means it can bind with the cell better, and that means it can enter into cells better. That is higher infectivity, higher affinity to infect, and that means it would go into a cell quickly, and then it would make its copies. Those would come out, then they would go into the next cells quickly, and then those would come out, and the virus would very quickly spread. That does not necessarily mean that our immune system will also be blocked. So the folks who develop cytokine storm, they have some genetic predisposition, or they have some internal environment. So it does not matter for them that it is rapidly developing in them or not. Now, let's say if somebody does not have that predisposition and in them this virus rapidly develops, then their immune system would take care of it as it would have taken care of it if it was slowly, a little slower developing. Not too slow like a vaccine, but if it was developing slowly as well. So the lethality just because of infectivity would not increase. Yes, this is true that if it comes into my body, for example, and it is so infective that it is just running around in my lungs and very quickly destroying them, while my immune system is still sitting at their beds or their sofas waiting 14 days to become active, and during that time the virus has just killed me, then that is possible. But other than that, the cytokine storm would only occur in those who are predisposed to it, and still not occur in those who are not predisposed to it. Does not matter how quickly the virus can enter a cell or not. So that is the same outcome for the the long haulers as well. Long haulers, let's say if the virus can hide in our body because our immune system is not responding, then yes, if the vaccine is doing the same behavior, that immune system is weak and the virus is able to then start entering the cells and live there, then we have a problem. Good question, Jan. Christy, if you read the ingredients on AstraZeneca vaccine, it contains tissue of aborted baby. There was a video circulating explaining how to research it. The video was by Polly Tommy. Christy, I have actually talked about that video. So most of the people, anti-vaxxers who yell at me, or folks who may not be anti-vaxxer but do not want to have the fetal tissue, they use that video because I had talked about that video and talked about how wrong that was. So then the responses are in all kind of ways. Somebody made a comment that her own child was damaged by vaccine, so give her some compassion. And I don't feel that somebody who had a damage, all compassion for that, but they don't have a license to start going and killing others because their own child got damaged. They should actually become even more sincere and honest and passionate and compassionate towards other humans, that this does not happen, instead of starting to do this. That is one. Then somebody said that she is right and you are wrong, so I can't do anything about that. I can only talk about the facts, and I have done a video about it. Cool. So I think this is what we have. I'm St. Clair. Who is the troll? I did not pay attention to the comments today. I would block them if I know them. Somebody became very upset with me on YouTube last day and said, "Why do you talk with people while you're teaching? Are you a chat program?" And I think the soul of my work is interacting with everyone here. Carlos says, question, hi doctor, I get the ivermectin must be stored below 60 degrees Fahrenheit. If my pills were stored a few degrees above that for about 15 minutes, are the pills still good? I left as soon open. No, they're fine. They're fine. So Rod E, I have talked about this many times separately. Maybe I should talk about this specifically. This specific point of the survival rate is a very it's misinformation that once again would get people killed. Here is why it is important to keep in mind that survival rate, the way these are being calculated, is wrong. And I had discussed this before. Let's say we have a community. Here is the community. In this community, let's say we have 100,000 people. And the outbreak starts in this community. And the outbreak, the very first month, let's say, there were 1,000 people who became ill. And then out of those 1,000, let's say one person died. So 0.1% death rate. What they do is, these folks who talk about survival rate like this, although the real survival rate for the given data, I'll get to that in a second. What they do is they take the whole population and they say, well, it is one person out of 100,000. And that is a very low number. Why are you scared? What they ignore is that the pandemic or the outbreak has not finished here. If it had finished here, then you could pick up the final data and then do the division with population and say this was the final number. But this pandemic or outbreak is still expanding. So using this number to divide with this number is disingenuous. The right way to do this is to look at the number of cases, confirmed cases, and then divide it. And that would at least give you some idea. Another better idea at this time, while the pandemic is still expanding and we do not know how much it will expand, is to look at the hospitalized patients, for example, and then see out of hospitalized how many are dying, and then see how many out of the cases that are becoming hospitalized. So currently the data stands at out of every 100 people, about 20 people become hospitalized or severe. Out of those 20 people, anywhere from 1 to 3 people or 5 people become ICU admitted. And then out of them, 1 to 3 people die. That is the thing. So if you look at that, then the survival rate is actually out of every 100 people, there are going to be 3 who are dying. But if you talk about survival rate in ICU, then out of 5, 3 die. If you talk about the survival rate of the hospitalized, then out of 20, 3 die. But when you take the whole population of the US and divide that over the total number of deaths and say, well, that is a very low number, that just in general is the wrong way of doing math. But this is what is a problem, that people are doing such maths and they are causing damage. And I don't know why they're doing it, meaning what do they get with that? Correct. Steve, your comment is correct. And if they couldn't get into the hospital, which is a case now, for example, that when we don't wear masks or don't do social distancing, and for both, again, when I say that we should not crowd, people say, you are a Democrat and you have a problem with Republicans. For Democrats, they should not crowd, and for Republicans, they should not crowd. Look at what is happening in LA now, that they are trying to treat people in the gift shops and in the other empty areas. And I was seeing that even the corridors, that is not a good situation. And anybody could be there. I could be there. I am above 50. Every time I think about myself, I feel that I'm at risk and I can end up there. So we have to be careful for these things. Makai says that, can you please look at the World Economic Forum website? I would do that. Wayne says that Dr. Drew came down with COVID on Xmas. He said he had an infusion of the monoclonal antibody therapy, bamlanivimab, took dexamethasone. Yes, I have been connecting with him. So the latest discussion, so he said to me was, I had asked him that he got some test or not. He said, so he has gotten, he's done all those, ivermectin and those things. And he said, now I'm on Decadron and on doxycycline and bamlanivimab. And so then I was talking about some more things, and his his saturation is pretty good at this time. So I think he will be recovering soon. Bob says, can you review the current monoclonal antibody medications, Regen or Lilly, as well as antibiotic? So I have already talked about favipiravir. It's one of the previous discussion. I've talked about Regeneron as well when Trump had used it. And a couple of days ago, before Trump's infection, I had talked in detail about it as well. So can you please just search those videos? I've talked about them. Cool. So this is the all right. So it looks like it is thank me later. So acoustic theory, I've blocked him as well. JMT Hero question. I remember you mentioned about the deletion of 2 nucleotides on spike protein on the new variant. Isn't the whole structure of the protein will change like the sickle cell disease? No. So what happens is that these changes do create the 3D structure of our proteins, but they also help with the affinity. So they do a lot of functions. These 2 changes have not caused magnetic change within the protein structure, that the protein structure changes. So in the sickle cell, the protein structure start changing. What happens is one structure, the beta chains become distorted because of the valine, and then they get entangled with the alpha chains and they just make long precipitates. That is not the case in this case. So it depends what kind of shape change occurred. Yes, Luffy is a troll be gone. So thank you very much. Happy New Year, and I would see you on Monday. And I forgot to say that my traditional thing. So please like, subscribe, and share. If you wanted to buy me a coffee, there's a link in the description. If you wanted to support their work, my work, there is a link in the description for that as well. And have nice coffees and nice drinks, and have a nice New Year. See you on Monday.